You are 34, alone in a room, breathing for someone. Here it is legal, there it is not. Year 1 pays $97,552. 11 years later, the same hands pay $251,500. The difference is not skill. 2 letters on a Medicare claim decide it. One pair pays that case at 100%. The other pays the same case by the same hands at 50%, and gives the rest to a doctor who may be in another room. This is every level of a nurse anesthetist's career, and what it costs to climb. If you want to see how these jobs really pay, subscribe so you do not miss the next one. We start at level 1, the intensive care nurse. The intensive care nurse earns $46.90 an hour, roughly $97,552 a year. Most of them are 24 to 30. You run 1 or 2 patients, not 8. You manage a ventilator, an arterial line, and 3 drips that argue with each other. You titrate a drug that moves a blood pressure in seconds. Your second year, you chase a low pressure with a vasopressor for 40 minutes, before anyone checks the arterial line has gone flat against the vessel wall. The pressure was never that low. Getting in requires a nursing degree, a license, and a unit that will take a new graduate. Most who try to move up never leave the unit, and rarely because they cannot do the work. The next step means 3 years of paying tuition instead of earning. Here is what nobody tells you. The accreditor defines critical care by the equipment, not the ward sign. It counts only if you routinely manage invasive monitors, cardiac assist devices, ventilators, and vasoactive infusions. That definition is the first gate, and it is the one people fail without knowing. The training is 3 years, and you do not get paid for any of it. The Council on Accreditation of Nurse Anesthesia Educational Programs sets the floor. A minimum of 1 year full-time as a registered nurse in critical care, a curriculum of at least 3 years of full-time study, at least 2,000 clinical hours and 700 cases before you finish. Anyone accepted into an entry-level program on or after the 1st of January, 2022, has to graduate with a doctorate. The same standards forbid programs from employing students as nurse anesthetists by title or function, cap student time at 64 hours a week, require 10 hours of rest between clinical duty periods, and bar any student from giving direct patient care longer than 16 continuous hours. Read that list again and notice what it describes. It is not a school schedule. It is a residency that charges you tuition. The newly certified nurse anesthetist earns $67.30 an hour, roughly $139,980 a year. Most of them are 30 to 36. You sit at the head of the table with a machine on your left. You induce, you intubate, you hold a person at a depth where they feel nothing, and you bring them back. Your first solo month you extubate a patient who is answering questions and following commands. 90 seconds later the airway closes anyway. You mask, you push a drug, you go back in. Nothing bad happens and you never forget it. Getting in requires a doctorate from an accredited program, a pass on the National Certification Examination, and a state license. 89.3% of first-time candidates passed that exam in the most recent reported year, up from 84.9% the year before. Here is what nobody tells you. The exam is not what thins the field. The critical care year is because you have to get hired into the right unit before anyone reads your application. The license is national. What it lets you do is not. 3 separate gates decide what you are allowed to do, and they stack. The first is federal. Medicare rules say a nurse anesthetist works under the supervision of the operating practitioner or an anesthesiologist, unless the state is exempt. The second gate is that exemption. Since November of 2001, a governor can opt a state out by writing 1 letter to Medicare attesting that the boards of medicine and nursing were consulted and that it fits state law. The letters take effect on submission. 27 states and Guam have sent one, starting with Iowa in December of 2001 and running through Vermont and Ohio in July of this year. The third gate is the hospital itself. Medicare guidance is explicit that a hospital may permit unsupervised practice where a state has opted out. not that it must, and that medical staff bylaws set what each category of practitioner may do. You can be independent under federal rules, independent under state law, and still supervised because a bylaw committee voted that way. The medically directed nurse anesthetist earns $86.94 an hour, roughly $180,840 a year. Most of them are 32 to 45. You do the whole case yourself. An anesthesiologist directing up to 4 rooms comes in for the induction and the emergence, signs the record, and is elsewhere for the middle. Nothing about your hands changed. The paperwork did. You call for the directing physician during a case that is turning, and he is 2 rooms away. He arrives in 4 minutes. You had already fixed it because there was nobody else to. Getting in requires the certification, a group contract, and a hospital with an anesthesia care team model. A meaningful share stay on this rung for a whole career. It is salaried, and somebody else carries the last signature. Here is what nobody tells you. If a physician oversees more than 4 concurrent rooms, that is medical supervision rather than medical direction, and Medicare pays only 3 base units for the case. The hands are the same on every rung. The claim form is not. Here is the money mechanism, and it is 2 letters. When a case is billed QZ, meaning a nurse anesthetist without medical direction, Medicare pays the full amount, the same as if a physician had done it alone. When the same case is billed QX, meaning a nurse anesthetist with medical direction, the Code of Federal Regulations sets the payment at 50%, and the directing physician bills QK for the other 50%. Same patient, same drugs, same person at the head of the table. 2 letters. The physician may be directing 4 rooms concurrently, which is the maximum the regulation allows before the arrangement changes character again. Nothing in the split reflects who was in the room. It reflects a supervisory relationship that has 7 documented requirements attached to it, and those requirements are the thing that gets audited. This is the whole economics of the profession in one field on a form, and it is why the argument about supervision has never really been about safety. The staff nurse anesthetist earns $113.75 an hour, roughly $223,210 a year. Most of them are 35 to 50. You are on a call rotation now. You take the trauma at 2 in the morning, the emergency section, the airway on a floor where nobody knows what to do. You take a handoff mid-case, get the essentials in 90 seconds, and 40 minutes later find a drug running that was never mentioned. It was in the record, nobody said it aloud. Getting in requires years of case experience, a group that trusts you unsupervised, and a call schedule you survive. In one survey of nurse anesthetists inside the Veterans Health System, taken in 2024, 38.7% scored high for work-related burnout. One system, a low response rate, and still the only published number. Here is what nobody tells you. Federal wage tables stop printing the top of this occupation. The 75th and 90th percentiles carry the same footnote, at or above $115 an hour. The top quarter of this job runs off the edge of the government's table. The independent nurse anesthetist earns $119.38 an hour, roughly $248,320 a year. Most of them are 38 to 55. You practice in an opted-out state, in a facility whose bylaws let you. Your own assessment, your own plan, your own case, your own orders. Nobody countersigns. Your group bills QZ. 6 months in, you take a patient with a cardiac history a directing physician would once have argued about. There is no argument to have. You choose, you proceed, and the weight of it is different when nobody is upstream. Getting here requires an opted-out state, bylaws that permit it, and a group willing to bill without a physician on the claim. A fair number never move to this rung even where the law allows it, and not for lack of confidence. The jobs are where the population is thin. Here is what nobody tells you. Staffing firms advertise locum work at figures well above any salary line, and those same firms are the only ones publishing them. The line that decides all of it was never drawn by a hospital. On the 10th of October 2019, an anesthesia practice in Traverse City, Michigan, and 6 of its anesthesiologists settled with the federal government over how they had billed. The allegation was that they submitted claims to Medicare as medically directed when those services did not meet the regulatory requirements and conditions of payment for billing them that way. The practice paid $607,966 to resolve it. Nobody alleged a patient was harmed. Nobody alleged the anesthetics were wrong. The case was entirely about whether the supervisory relationship described on the claim form matched the one that existed in the building. That is the point worth sitting with. The federal government does not audit whether the nurse anesthetist did the case well. It audits whether the doctor who took half the fee did the 7 things that entitle him to it. The sole nurse anesthetist earns $120.91 an hour, roughly $251,500 a year. Most of them are 40 to 60. You are the anesthesia department of a critical access hospital. There is no second person. When an airway goes bad at 4 in the morning in a building 60 miles from anywhere, the plan is you. Your first winter, a section comes in at 3 and the nearest anesthesia backup is an hour of icy road away. You do it alone because the alternative is not doing it. Getting here requires an opted-out state, a rural facility that credentials you alone, and a tolerance for being the only one. A number of them leave after a few years. What ends it is almost never a case. It is being on call every night and calling that a schedule. Here is what nobody tells you. One survey of rural practice put the median above the national median for the whole occupation. The least supervised job in the field is also the best paid. There is a seat above all of this that pays less. The chief nurse anesthetist runs the schedule, sits on the credentialing committee, argues the group's contract, and gives less anesthesia every year. Published figures for that role sit below the national average for the people it manages. On a sample too small to quote confidently, the trade is real anyway. You stop being the person at the head of the table and become the person who decides which colleague gets to be. Some take it because the call schedule ends. Very few take it for the money. Intensive care nurse, $46.90 an hour, 1 patient at a time. Newly certified nurse anesthetist, $67.30, first solo cases. Medically directed nurse anesthetist, $86.94, half a fee. Staff nurse anesthetist, $113.75, on call. Independent nurse anesthetist, $119.38, nobody countersigns. Sole nurse anesthetist, $251,500 a year, 60 miles from anywhere. 2 letters. QZ or QX, same room, same patient, same hands, and half the money. Everything in this career that looks like a promotion is really a change in who is allowed to sign, and every one of those lines was drawn by somebody who has never met you. Next, every level of a police officer.